Push my button. Good afternoon. Thank you for joining. Thank you for joining the Senate Finance Committee. Today's Thursday, January 23rd. We're going to start with 3 briefings today from starting with the Maryland Healthcare Commission. And Mr. Steffen and David Sharp, would you like to come to the table? And then that will be followed with presentation from CRISP and then a virtual presentation from Epic. So thank you.
Thank you, Chair Beidel, members of the commission, members of the committee. Ben Steffen, Executive Director of the Maryland Healthcare Commission. My role today is to be primarily the orchestrator, where my colleague David Sharp will present the principal findings on progress in implementing the protected health legislation that was passed in 2023. We've made great progress, and we really want the committee to understand the successes, the challenges, and the remaining challenges as we implement this important piece of legislation. If we can go to the next slide, is someone... So just to summarize the key components of the law, the Senate Bill 812, excuse me, I'm on the wrong slide here. It did add some important provisions pertaining to the protection of reproductive health information. It established new state entities, the Protected Health Commission. It directed the Maryland Healthcare Commission to take steps to change its regulations, as well as the department to establish a set of codes and processes for protecting information. We've made progress in all of those dimensions, but we want to emphasize that this has been a complex task, and I want at the outset to emphasize that the work of the health information exchanges and the hybrid entities that are serve as both health information exchanges and as electronic health record vendors has been essential to this effort. I also want to note that through the work of the Protected Health Commission that we have engaged a new set of stakeholders that value the importance of protected reproductive health and the rights of consumers to use those services without the intervention of other state entities outside our borders. So we can go to the next slide. I just want to cover this as we kick this off. A lot of boxes, clouds and bullets here, but I want to point out that the Healthcare Commission, the Protected Health Commission, as well as the Maryland Department of Health, have played key roles in the development of the regulations that are essential to actually activating the legislation. In particular, you'll notice in the center of this slide, the health information exchanges. They are the primary subject of regulation and oversight. They have the ability to transmit as well as to filter or block information as it passes across the information infrastructure. Traditionally, HIEs, the role has been to facilitate the exchange of information. This legislation really assigns a new role, which is to appropriately filter information as it passes among health systems and health providers. Something that I think is new, and I think that you're going to hear from the exchanges that are speaking today, that it has proved to be somewhat challenging. Nonetheless, they're making progress. Lastly, if you look to the right of this slide, you'll see the healthcare providers and practitioners. Important to note that there is no direct authority as a result of the passage of 812 on providers. That differs. Other similar statutes in California have penalties assigned to providers as well if they do not conform with that law, which becomes effective in 2026. Maryland has taken a different path, and all of this effort is really going to be implemented through what I would call the midware or the technology vendors, that there are no present penalties on providers if they are slow to implement these new regulations. But I would appeal to them. I think this is a very important legislation. It's important to individuals who come in the state for protected health care services, but it's also important to residents that live here and may want to limit who has access to certain sensitive health information pertaining to reproductive services. With that, I'm going to pass on the details of this work that we've been doing over the last year and a half to my colleague David Sharp. Then I think we'll have presentations from Nicole Sweeney, General Counsel at CRISP, who also serves the important role as chair of the Protected Health Commission, a clear important role, a public role, and her knowledge and wisdom are going to be essential to that Commission continuing to play a role in shielding new codes from disclosure. Lastly, Sasha Termont, a director at EPIC, is going to talk specifically about the challenges and successes EPIC in particular has faced. Important to have EPIC here. It's the largest EHR vendor, but it also behaves as a health information exchange. Think of it as when you use Care Anywhere through your MyChart features, you're actually using EPIC's HIE functions, which are common today in most of the advanced EHR systems here in the state. With that, I'll pass this over to David.
Okay, thank you, Ben, and good afternoon, Chair Vidal, Vice Chair Hayes, and senators, members of the committee. It is my distinct pleasure to be before you and present on several important topics today. Well, I'd like to structure it a bit like a conversation, so please, unless it's the preference of the chair, I'm happy to take questions during the presentation, but I, of course, yield to your discretion, ma'am.
David, we usually wait till the end. When I say the end, after your presentation before CRISP and EPIC, we'll hold questions till then. Thank you.
Very good. So,
Move the mic closer.
David, will you move the mic closer? That's it. Thank you.
is that better?
Yes.
Okay. All right, so let's start off building on some of the points that our Executive Director, Ben Steffen, made as we lay the framework for what we're talking about with the legislation implementation. We'll start by the regulations, which became the foundation for building in the roadway to success, and we'll call it, because the health information exchange organizations have done yeoman's work. It begins with the identification of the codes, and the Maryland Department of Health developed regulation. That regulation is COMAR 101108. It's titled Abortion Care Disclosure, and they worked with provider groups and other stakeholders to identify codes that would serve as the basis for what HIEs would block. So it starts there. These codes encompass legally protected health information and are subject to restrictions for disclosure. The MHCC, we set out to develop the framing network for both electronic health networks, which you probably know as EHNs or claims clearinghouses. Many of you are familiar with that, as well as the health information exchange, the two regulations that govern. For the record, it's COMAR 102507. Certification of electronic health networks and medical care electronic claims clearinghouses, and COMAR 102518, health information exchanges, privacy and security of protected healthcare information. We have approximately 29 electronic health networks in the state that are certified to operate, and we have about 16 HIEs that are registered to operate in the state. So we have a lot of organizations that these regulations provide the framing pathway for implementing the requirements of COMAR 101108. So let's travel along. Ben mentioned a little bit about what HIEs and EHNs are, so let me just quickly summarize again a little bit about them. HIEs determine, control, and have the discretion to administer any requirement, policy, or agreement that allows, enables, or requires the use of any technology or service access for access, exchange, or use of electronic protected health information. So Ben mentioned that these organizations can be electronic health record vendors who have a component that is capable of exchanging protected health information between different providers and different entities. And the regulations that have been implemented, again, are 1025-18 for the HIEs. On the electronic health network side, they're the organizations that handle administrative transactions. The administrative transactions, some of you would probably be familiar with them as claims or referrals. To give you a couple examples, an electronic health network moves transactions between payers and providers and other organizations to increase the healthcare operation efficiencies and reduce administrative burdens. They're the pathway, the electronic pathway between the provider and the payers. So that's probably the easiest way to think of them. Payers that accept electronic transactions in Maryland are required to use a certified, MHCC certified electronic health network vendor. And again, I mentioned there are about 29, and the list is included in the appendix section for the record. So where are we today? As we think about implementing the requirements of the legislation, there's been notable progress made by certified EHNs and registered HIEs, and collectively I'll refer to them as vendors, to develop and implement the technical solutions and policies for legally protected health information with a date of service of May 31st or later of 2022. Nearly all HIEs are working with Maryland clients to implement system updates and consider other compliance measures to comply with the statutory requirements. HIEs have noted for us on various occasions that the legislation does not include penalties for noncompliance to providers. So we'll talk a bit more about that, but that is a challenge for the vendors in order to ensure that they meet the requirements of the regulations. Generally speaking, more time is needed by the technology vendors as well as the clients who use the solutions to implement the requirements for blocking text that's associated with the restricted codes that must be blocked, as well as controlling directed consent between a patient and a different provider other than the one providing care. So we'll come back to that as well. For the electronic health networks, it wasn't nearly as challenging for them to implement the requirements because the provision in the law allows for the use of data for the adjudication of claims. And primarily, that's how the EHNs are using information. So let's talk a little bit about some of the highlights of implementation, just briefly. It's worth noting on the regulation side, we had 9 months to get the regulation. The legislation required 9 months to get the regulations in place. On September 22nd and 23, MHCC released draft regulations for informal public comment. In November, the emergency and proposed permanent regulations were approved by the MHCC and submitted to the Joint Committee on Administrative and Executive Legislative Review. In January, the amendments to COMAR 1025-07 and 1025-18 were published in the Maryland Register for a 30-day public comment period. In February of 2024, the emergency regulations were published in the Maryland Register and were effective on July 11th and July 9th for COMAR 1025-07. And on May 3rd, the final regulations were published in the Maryland Register with an effective date of May 13th. So we made pretty good timing, and we did this because we worked closely with the stakeholders, and we worked closely with the electronic health networks, to be specific, closely with the HIEs to make sure we could keep things moving along. And I'll tell you a little bit about that here. To help formulate what was included in the regulations, we had a series of stakeholder engagement meetings. and also to help them better understand what the requirements were and to provide guidance on implementation. So several of them here, starting in December 18th of 2023, we had our first town hall where we responded to various questions. And we had several other specific town halls related to answering questions and getting feedback from them as it relates to the drafting of the regulations. They were in December, then in April of 2024 and May of 2024. In January in 2024, we released HI implementation guidance clarifying the regulatory requirements. We also released the EHN guidance in early February. So we started with the HIEs because of the complexity of the implementation track they needed to follow. In March, we engaged members of the Electronic Health Record Association, and since then, we've been attending quarterly meetings to keep the communication open and address questions they have, plus also learn about how they're making in terms of their member progress in implementing the requirements. In September of last year, we were notified by MDH that the regulations specifying the codes were published in the Maryland Register on September 6th with effective date of September 16th. So once the codes became active, the work of the vendors to set up the programming to block the codes, they moved forward to essentially turn it on, if you will. A little bit more about reporting and implementation. In October of last year, we submitted our first quarterly update, which the legislation requires us to do through second quarter of 2025, letting the legislature know, the General Assembly know where we were with implementation, the progress the vendors were making, any challenges that we thought we should point out. In January of 24, all vendors submitted what we called an affirmation of compliance or an implementation plan. The compliance was whether if they could obviously meet the requirements of the regulations, and if they needed more time and they had a structured approach, they provided an implementation plan. And you'll see as we go a little further that most vendors were able to block the codes, and that's important to note. The challenges come in specifically as it relates to text-based information related to the codes. So I'll talk a little bit more about that in a few minutes, as well as the directed consent. In April, select vendors with an implementation plan submitted their required status reports. So we had a couple of status reports along the way. And in June, vendors submitted a validation, which is when the requirements were supposed to be implemented. And most HIEs noted that they needed some additional time for implementing elements of the requirements related to blocking legally protected health information. And we've been getting ongoing updates, again, working directly with the members of the association as well as the association itself. So we noted as we started the discussion that there are some challenges, and I think it's worth calling out here. You will probably hear from the CRIS folks as well as the EPIC folks about some of these challenges as well. EHR vendors report that developing and implementing the necessary technical compliance to prevent the release of legally protected health information and sharing it to a specific treating provider, directed consent, creates a challenge. Restricting unstructured text-based information which supports the code compounds vendors' compliance timelines. It takes much longer to develop code, if you will, that looks for text and blocks the text, as opposed to having a specific number that you can more easily identify that in a program. Provider organizations, on the other hand, have also noted challenges around implementing. The provider organizations say they need about 12 to 24 months to implement any kind of software change made by an electronic health record vendor or HIE. And they do that because they run through a series of what's called user acceptance testing. Because of the complexity of the health systems, by way of example, they can't simply just say, okay, we have the latest upgrade and we'll install it. They screen it very carefully because their organizations are, any misstep, if you will, if there's something wrong with the software or a version, they're quick to go back to the electronic health record vendors and say, we found a glitch, there's a challenge, but they also want to make sure it works for them because these electronic health record systems are integrated broadly to other solutions throughout their systems. So it requires a good bit of work. And actually, for just to note that because it takes time off to test user acceptance testing, generally other versions will already be in the pipeline to implement. So the vendors are they're pushing out changes, and the users are trying to be very methodical and careful to make sure that it works for them and it works for their solution. And so they go through these thorough testing. So oftentimes there's a schedule that's created, and a health system could be 6 months to a year down the road and still have 2 versions behind the one they're already implementing. So hopefully that gives a little sense of the complexity and the time that's involved. So let's just keep going. Here is kind of a quick snapshot, if you will. And the colors are more just to articulate, but let me just kind of walk through it. So what we're saying in 2024, there about 65% of the vendors were able to block the codes that are in the COMAR regulations 10 from the Department of Health. And so the estimates for the other share, if you will, is that there's a small percentage in 2025 and even a smaller percent in 2026. But because of the technical challenges of implementing the technology, the requirements, some vendors just need more time. And that's what we hear often. As we think about the text, which supports the codes, you see a smaller share. We're able to do that in 24. More individuals can do it in 25, and then the remainder, if you will, can do it in 26. And the same kind of perspective goes with the directed consent. You can see that the majority of the vendors will have it implemented in 26, but they need that time to work through all the technical challenges. The detail, again, is in your appendix section if you wanted to know by vendor where they are. So compliance with the regulations. So the regulations have an enforcement arm to them as instructed within the regulations. And at this time, the MHCC has not issued any fines to vendors for noncompliance. So the vendors were requested to submit biannual implementation updates in 25, the first one due in March of this year. The vendors were given a waiver on the fines through 2025, but they still have to demonstrate, as long as they can demonstrate that they're making progress on implementing the codes completely, the text-based information, and the directed consent. So looking ahead, to give you a sort of snapshot about what's happening in 2025, the MHCC will continue to submit quarterly updates to the Senate Finance Committee and HGO Committee. We've done so for the end of the fourth quarter of last year, and we'll work on the others as we go forward for the first 2. We'll continue to gauge implementation progress, working with the electronic health record vendors and EHNs as appropriate, and to provide support and identify any interventions that are needed to keep everyone on pace with the schedule that's been framed up in which we've noted. We'll also consider updating any of the guidance documents. I mentioned we had a series of town halls where we produced guidance material to help with the implementation journey. And we'll provide ongoing consulting support to the vendors to help them address any implementation questions or challenges. And we spend a lot of time working one-on-one with the vendors. So we're really trying to stay close and help everybody get to the finish line as best they can, expeditiously as they can. So with that, let me pause and thank you all for the opportunity to provide an update, and I'm happy to answer any questions along with my executive director.
Thank you. And David and Ben, thank you so much for your work. We've given you a lot of work this year. I have this stack of reports on my desk. So I thank you and your team for really helping us so much. I do have a question from Senator Ellis.
Yeah. Thank you, Madam Chair. Thank you for a very technical presentation about a very technical topic. So one question I have, you mentioned that the legislation doesn't call for fines or penalties against providers who don't do what they should do. When you say they're providers, who Is that the doctors, medical facilities?
Yeah, would you like me to answer?
Go ahead, David.
So thank you for the question, Senator. So when we talk about providers, we're talking about the users of the solution. So it could be an ambulatory practice using a solution. So when the vendors are saying it's not going to the providers, it's meaning their end users, which could be a health system who installs the system broadly to the hospitals as well as to the physician practices that they own. It could be a clinic who's using a software package. But it is noted that the fines only go to the EHNs and HIEs. And
Those are the vendors.
those are the vendors, sir.
And who the providers of the
That's
software,
correct.
the computer.
And we'll hear that from the HIEs, I'm sure, as well, because they're sort of in a kind of a quagmire because they have to develop the technology and they have to make sure people use it because there's not a requirement that a health system or a provider of sorts installs the latest version in any timely manner because of they have a user acceptance testing program that takes an exacerbated amount of time, perhaps.
Yeah.
Yeah. So you're saying a provider, a medical facility, a doctor can choose not to upgrade, and then there's no penalty for that?
It's not usually the physician themselves because they're users of a system typically. It's the organization that owns or licenses the software.
But that practice have to
The practice.
pay for the software and upgrades.
Yes, they have to. They make payments for upgrade and maintenance, and the organizations, the vendors, upgrade the software periodically for lots of reasons, and this just happens to be a requirement that they would have to upgrade. But
I'm sorry, requirement
that they have to upgrade their technology for the providers to use.
Okay, so the providers guarantee that they will upgrade their technology. Is that
Providers will upgrade. It's just timeliness of it.
timely? So when you say timeliness, because this is a very important issue now with this climate especially. So when you say timely, is there any provision in the regulations saying that they have 6 months or
No.
6 years?
Because the regulations aren't, because the legislation doesn't target the providers, it targets the.
We don't like that word target.
Oh,
We don't
sorry.
target providers.
It addresses the challenges of the law for implementation by the EHNs and HIEs.
Yeah.
And so when we think of it that way, the regulations are the framework for implementing the legislation.
Okay. And so you said several times about providers, no fines, no penalties. It seemed like you were concerned about that. So what's your personal feeling about that?
Yes,
If
so-
you can share that.
Oh.
Okay.
So I think, yeah, and this issue has not been, widely discussed at the commission, but I think at this point, I can say that my sense is that the commission would take a position of, let's wait and see. David, I think, has clearly laid out that if there will be a time period over which all systems and providers in the state implement these changes consistent with when a software upgrade is made by that facility or that practice. And we'd like to say, let's just wait and see. As I noted, the California law does have penalties on providers who don't move forward with their requirements. I would say that we think this approach should work well. I know that you have probably heard from some health systems and some providers about concerns about implementation. I think our approach of emphasizing that the vendors should embed these enhancements in their systems, and when those upgrades, capturing those enhancements are implemented, the law would be implemented. But we will be paying particular attention to the late implementers because those are the ones that we are most concerned about. It likely those slow implementers may have other technical reasons why they can't move faster, but at some point we are patient, but our patience should not be endless.
So one final question, Madam Chair. At what point will you be able to guarantee the women of Maryland that their private health information is protected?
So under this particular law, I think the last system to implement, based on the data we have, is at the end of 2026. Is that correct?
That is correct.
Those are what I would characterize as slow implementers, and we're going to look at this, carefully as they move on. To give you an illustration of what David said, for example, one vendor updates their software quarterly. Think of it as the same way you get updates on your Google or Apple phone. And this particular system has not only not implemented the changes that were introduced by the vendor in May or June of 2024, they are still yet to implement the changes that have nothing to do with this law from February of 2024. So, they're almost a year behind at this point, but it's not because of reluctance on this. It really is related to the broad questions that when we get an upgrade, we just don't, as we do with our Apples, say upgrade tonight and it happens. With these complex systems and their integration with other systems at that hospital, the IT department has to be very cautious, and David outlined the test procedure they go through. But we do think that our patients will run out, and we will be moving to pushing some of the systems to upgrade a little quicker. But we're still at a point in this implementation where we think gentle pressure is giving us the dividends we want. But I absolutely endorse your position that we need to say at a point certain that we've done everything we can under the law to protect information.
Thank you so much, and you really pleasantly surprised me with giving me a date, so I really appreciate that.
Hold us accountable.
Thank you, Madam Chair.
Thank you, Senator. Senator Lamb?
Thank you, Madam Chair. Thank you for the update and the presentation. I did have a question about gender-affirming care. We had legislation previously about shielding gender-affirming care in the medical record system. Do you have an update on when that piece might be completed too?
So the Protected Health Commission has talked about gender-affirming care. We have, at this point, no firm statutory requirement to implement that under this particular statute. We are aware that is kind of the next stage in this endeavor to protect information. Certainly, some of the information that's coming out at the national scene is quite disturbing, and having a transgender niece, I can share with you that these concerns for people that have this, going through this care, it's not nothing. It is a concern, and we're going to pay attention to that. The Healthcare Commission did a paper on the prevalence of gender-affirming treatment that Senator Lamb, if you and other members of the committee would like to see, we'd be happy to share it with you.
So just following along on this diagram then, so it's in this stage here where there's a Protected Healthcare Commission, I guess, is that where you're saying that it's, because you said there's no statutory requirement right now for gender-affirming care to be protected in this way. Is it working its way through this process?
It is working the way through the system slowly. I know that there is a subcommittee on the Protected Health Commission to examine how that information can be protected.
So according to this, there's a subcommittee working within this commission. The commission will provide a recommendation to the department?
The commission would provide a recommendation on codes that could be screened. Then it would be in the department's responsibility to modify the regulations to incorporate those codes. If those codes are then incorporated in the department's regulations, we believe that we could move forward with asking the EHI vendors to screen and shield that information.
Okay, so in that process you just outlined, there's no need for a statutory requirement here. This could be done via this process.
I believe it could be done through this process if the General Assembly in their judgment felt they wanted to set some timelines for this. I think a statutory change would be the best way to affect that.
Is this something the Department of Health could also just recommend that codes be protected, or does it require the commission to act?
I think that well, I don't want to speak for the department because I don't know for sure what their position is on this issue, but that's conceivable. We can take that question back.
Yeah, if you could get us an answer on, and it doesn't need to be specific to this, just in regards to the process, could the department simply identify codes that they want protected, send them on to MHCC, and then follow the rest of this process? Right.
I think that the secretary could, under her own authority, make a determination. I think the role of the Protected Healthcare Commission is respected at the department. So I think stay tuned on what the Protected Health Commission, the executive director of MHCC serves on that commission, as well as primarily healthcare providers and some technology experts. As I mentioned, Ms. Sweeney is chair of that commission.
Okay, and you referenced earlier, I guess, some of the progress, for example, that California has made. What have they? Do you have any familiarity with what they've done with gender affirming care and protections?
I think they have moved a bit further, but I'd want to get back to you with the facts as opposed to what I think is happening.
Okay, and the last bit here is that it was my understanding that I guess the industry, specifically like a representative from Epic, which is one of the large EMR providers, was invited to talk about the implementation difficulties at some of the prior meetings, but there was no one from the privacy kind of advocacy stakeholder side. Was that intentional at all, or did it just happen to be how that was, who was invited?
I think that's a good point, but I think we've recognized that in our deliberations to consider those representatives, but in terms of our presentation today, we didn't include a privacy rep.
Okay,
But
all right.
certainly a group of stakeholders, it needs to be, advice needs to be sought and perspective needs to be considered.
Okay, all right, thank you.
Thank you, Senator. I don't see any other questions at this time. Oh, I'm sorry, Senator.
No, it's okay, Madam Chair. Thank you. Can I ask a separate question from the presentation? Is that okay?
Sorry.
Can I ask a separate question from the presentation, or should I stick to the
I'd rather you
presentation?
take that offline.
Okay.
We've got a really busy day,
Thank you.
Senator. Thank you. I do want to bring up CRISP, the presenters from CRISP. You can begin.
All right. Can you all hear me okay? Bring this a little closer. Good afternoon, Chair Beidel and members of the committee. My name is Nicole Sweeney. I am the General Counsel and Chief Privacy Officer for CRISP Maryland. And as you may have heard, I am also the Chair of the Protected Health Commission. Today, I'm speaking with my CRISP hat on. However, whenever you all want to ask questions, I am happy to change hats. I'm just going to be very conscious and say when I'm wearing which one. So right now, I am wearing my CRISP hat and speaking to you as the state-designated health information exchange for the state of Maryland and our implementation on this law and these set of regulations. So I want to start off today by just saying it's really cool to be from Maryland. I am a Marylander, and I am routinely asked as part of a best-in-class health information exchange to come and speak across the country about these issues. And just a little vignette, I was recently in December speaking on a panel about some of these issues with folks from across the country, leaders in these in the industry for national networks. And it was pretty fun, I have to say, when some of the folks were saying, this type of thing can't be done. And I got to raise my hand on the panel and say, well, actually, not only can it be done in Maryland, we are doing it. So it's been a very difficult, challenging challenging 2 years, but you gave us a challenge 2 years ago in this room around the same time. And I'm happy to report that the industry has risen to the challenge and where we are today as CRISP. So thank you for not only giving me the bragging rights of having the coolest flag in the country, but also being able to do some pretty cool health technology things. So just speaking where CRISP is there a slide that I have to bring up, or? Do you all have it? I don't need to bring it up if it's, oh, okay, perfect. Okay, just want to make sure that you all have it. Great. So it's just one slide, and it's pretty technical, but I'm kind of trying to walk you through it from sort of a non-technical basis. So as of December 16th of this year, CRISP has been able to block the codes that were given to us through regulations. So those are no longer going across and being exchanged in both what we call ADTs, and this is the technical part that I'm going to try to untechnical for you, and CCDs. So ADTs are messages that come across very discreetly and say, hey, Nicole Sweeney went to the emergency room and she had this procedure done. So we're blocking those codes. You would only see that Nicole Sweeney went to emergency room. The procedure codes would not be related to them. And the same thing for the CCDs, which are the larger records. Right? You're going to see lots of different things in those records, not just that I went somewhere, but what happened, my primary diagnosis, any labs that I had. So those we're treating sort of separately depending on the situation. So if we get one document from a provider, then we are one document from the provider that has one of the codes in it, then we are not exchanging that document at all, because by taking the code out, it would be very obvious that something was missing. So we don't want to give someone a record, redact something, but have them be able to tell from the redaction that that issue itself was there. So if it's just one document that has that, we are blocking that document unless we have the consent of the patient in the next few months, which I'll talk about briefly. If we are doing what we call federating documents, which is taking documents from a lot of different providers and then passing them on, so you're just seeing one record about Nicole Sweeney from lots of different providers. In that case, we do redact the code set that is in the regulations, because you're not going to necessarily see, not even necessarily, you're not going to see a gap then, right? We're going to be able to reconstitute the record in such a way that you're seeing lots of records together and it's not going to be obvious for the gap. So that is for sort of a static document. Sometimes I think of them as a non-technologist, as a PDF. And then if for folks that use our portal, so that is something that you can log into for providers that might not be using our services through an EHR. When we are showing individual diagnosis codes, you can think of this the same way, sort of as a record, except that much like something, much like a website where you can kind of like scroll around and there are different tabs, you're going to see all the records put together in a way that makes sense for clinicians. In that case, we're also able to take out the codes and show the rest of Nicole Sweeney's records and observations and medications and things like that. Because again, at that point, it's not obvious that something's missing because you're seeing all of those things together. So we were able to implement all of those beginning on December 16th of this year. We are working actively right now on patient-mediated consent. We are lucky to be in the position that we have had patient-mediated consent for other types of sensitive health information, specifically around 42 CFR Part 2. If anyone has any interest in that. So we had that type of technology available already, and we are using the next several months. We expect it to be this quarter, released by the end of this quarter this year, where we would have patient-mediated consent. A patient would, just like with our other consent modules, be able to go into their provider's office and much like what happens right now, at least for me, I go into the provider's office, they give me a tablet and things to fill out. The provider would sit with the patient, explain the issues. We also have a FAQ that patients can go to, which was created by our Consumer Advisory Council then register consent. Initially, that's going to be to all treating providers, so the patient would be able to consent to all treating providers. Our plan is that by then the end of 2025, a patient would be able to select certain treating providers. So instead of saying you can release this information to all of my treating providers, they could say you can release this information to Dr. Steffen or Dr. Sharp, but not necessarily all of them. And we are on track to have that implemented by the end of this calendar year. So that is where we are. We definitely have challenges. We are not in the same situation as a lot of the EHRs because we don't have to wait for software updates. It's something that's just pushed to the providers and other folks when they use our systems. And we also have a pretty robust data lake, which is probably getting far too technical. We also are able to redact codes as long as they're computable in free text sections. It's just that, frankly, clinicians don't write CPT codes in free text sections, so there's nothing to redact. But if we, in the future, are given by the department or someone else, the real trick here is computable things. Computers aren't necessarily very good at guessing what something is, but if you say, in our experience, take out this very specific phrase or this specific sentence or take out the entirety of the free text, that's something that, with testing, we would be able to implement. But frankly, right now, most clinicians aren't putting RX norm codes or HEDIS codes or CPT codes in the text themselves. So it's not something that we have had to redact because it's just not there. So that's where we are. It's been a very, frankly, fun project in a lot of ways. And again, it's really great to be from Maryland and speaking on the national stage and being a leader in this area. So I'm grateful for the opportunity, and I'm happy to take any questions.
Thank you, Madam Chair. And I don't know who might be most appropriate to just answer this question. I know that we had passed this legislation focusing on ensuring that women came into Maryland were protected from those states that might try to track them down and prosecute them. But it also, these protections apply to women who have abortion services here in Maryland. The question I have is that, and I'm not sure what the answer is, do we see a dilution in the whole point of having electronic medical records available? Somebody has a serious incident in one part of the state, and the idea of being able to get that history, electronic medical records for a Maryland resident, wherever that is, they're being treated in a hospital elsewhere. And we've done a lot of work on trying to have electronic medical records for that very reason. Is there any thought as to how that, is there a conflict? How do we work through that? I'm just curious as to
Certainly.
how that plays out.
So as CRISP has implemented it, that would only be an issue if you are requesting that specific record from that specific provider. What I mean by that is, I'll use myself as an example. If I go to a provider and receive one of these protected procedures like an abortion, if another provider is asking for that record that contained the abortion, they would not get that record, but they would get any other information about me. Or if you were to use the CRISP portal, you would get stuff within that record. You just wouldn't get the CPT code about the abortion. I'll defer to David and Ben. I know there have been challenges with other EHRs. And then very briefly with my protected, I'm going to put my other hat on for a second and then take it off. That is exactly what you're talking about, are the kinds of conversations we have as the Protected Healthcare Commission, including with our conversations about gender affirming care, because we want to make sure that we're weighing that And then on a personal note, when I get these questions a lot from providers, it might be a little too glib, but I do tell providers sometimes, according to my provider, I exercise 6 days a week and drink less than once a week, from what my provider knows, and that's certainly not true. So providers are used to dealing with gaps in records, and we want to make sure that if it's an emergency, it's an issue. But I think and I know there are some providers in the room, so keep me honest, but providers are used to dealing with gaps and used to dealing with not perfect records.
Okay. Thank you, Madam Chair.
Senator Lamb?
Yeah, thank you for that update. And was just wondering if you were at all able to provide kind of a sense of where California is, for example, on gender affirming care.
My recollection is that they are pushing it to the providers as they're pushing the abortion codes to the providers. So it's up to and this is my recollection. I'd want to confirm that for you, Senator. But my recollection is that it is up to the provider to decide whether or not to put the code in, including on gender affirming care, if they think it would be subject to prosecution or investigation in another state in the country. So it sort of changes things. For what Maryland decided to do was say, instead of having each provider decide, we're going to have a set of computable codes for the HIEs and EHRs. My understanding is that California, both with abortion-related care and gender-affirming care, they're pushing that responsibility and that call to the provider.
So it's being handled at the provider level, I guess.
Correct. That's my understanding. Yes.
Okay.
But I would want to confirm that.
Okay. And then I guess to Senator Kramer's point, if the patient consents, the provider in the example that you gave earlier would be able to, that abortion record would be able to be shared.
Correct, yes.
And then, okay, I think that covers what I was going to ask. Okay, thank you.
Thank you, Senator Lamb. I don't see any other questions. We're going to go to Sasha from Epic, and it's going to be virtual. And as soon as we bring him up. So everyone has Sasha's PowerPoint. We can't do both, have him on the screen or her on the screen and the PowerPoint at the same time. So you want to get out your document that looks like this and get ready for this presentation. Sasha, welcome. You can begin anytime.
Thank you. Are you able to hear me all right?
We can hear you, but I think you're going to need to speak up just a little bit.
All right. Well, thank you. I'll try to speak up and let me know if it's too quiet. Thank you so much for inviting me to join you here today virtually. We really appreciate the invitation to talk about all the efforts going on to protect patient privacy. My name is Sasha Termott. I work at Epic. Epic is a developer of health information technology software, including electronic health records. And hospitals and doctors use our electronic health records around the world and across the country, including in Maryland. A little about my background. In my 19 years at Epic, I've had the opportunity to be involved in implementing a variety of different health information technology regulations. So both federal regulations like those put out by the Office of the National Coordinator of Health Information Technology, but also state-specific programs that affect electronic health records and interoperable exchange. And then in the last couple of years, I've worked with the hospitals and doctors who use Epic software in Maryland on the best ways to offer increased reproductive health privacy to their patients. Maryland passed one of the first reproductive health privacy laws of this type, and there's some aspects to how Maryland did that that have worked really well, focusing on abortion as a use case and defining the specific code sets to be filtered have allowed much faster implementation than some of the other regulatory approaches that we've seen. In the next few minutes, I'm going to give a brief status update on the work that Epic has done as an EHR software developer and on the work that hospitals and doctors that use Epic software have done on filtering abortions, codes, and related information. Then I have 3 recommendations to continue to improve the implementation of abortion privacy features and to make any future implementations of health information technology regulations smoother. So my status update is first, and I have a timeline in here. You've probably heard from Ben and David that there's far more milestones that I've omitted on my timeline as I was putting together what's happened over the last couple of years. But as you've heard, the Maryland bill that forbid the disclosure of abortion codes through health information exchanges was approved by Governor Moore back in May of 2023. The effective date was in December of 2023. That kicked off a lot of activity across the industry. MHCC was very busy with writing the regulations, answering all the questions from developers like Epic and others. EHR developers like us and their hospital and provider users were also very busy. At Epic, we worked first on helping our customers with what they could do with the privacy features that were already available in the software that they were using, given the tight time frame between when the bill passed in May of 2023 and the compliance date at the end of that year. After we worked with them on the short-term plan of what they could do right away, we turned our attention to what types of new privacy features we could add to our software that would provide them with more options. We designed in conjunction with the doctors who use our software, and in May of 2024, we released a version of our software with a new feature that permits healthcare organizations to exchange patient records with abortion codes and associated information redacted from those records. Healthcare organizations have begun upgrading to that May 2024 software version in the second half of 2024, and they continue upgrading this year. As they've upgraded, they do configuration to begin to use that redaction feature. And it's important to note, as you heard from Ben and David, that the healthcare organizations choose their own upgrade schedule. Most healthcare organizations plan their upgrades months or even years in advance so that they can align them with other projects that their IT teams are working on. That takes me to kind of 3 of the recommendations that we at Epic would offer for how to improve this implementation and any similar initiatives. The first recommendation I have has to do with safety. We at Epic were careful to design the feature that redacts certain codes and associated information from the electronically exchanged documents. In conjunction with physicians and patient safety experts, we heard concerns about the risks of not seeing a full record. Those concerns came from our own safety officer as well as from doctors that use the software. So our recommendation based on that, as the Protected Healthcare Commission evaluates the risks of disclosing health information services and make recommendations to the Secretary about what should constitute legally protected healthcare under the law, we recommend that they also evaluate the risks of redacting information about sensitive health services from the electronically exchanged documents. So it would be helpful to assess the risks of the current restrictions, as well as any future changes in scope that the Commission considers. My second recommendation has to do with stakeholders. Maryland's law leaves out some of the important roles of individual doctors and healthcare organizations as the stewards of patient healthcare information and the ones making disclosures. Electronic health records developers don't make disclosures of health information on behalf of their customers typically. Instead, we provide software tools that allow a doctor to disclose health information when that doctor has determined it's appropriate to make a disclosure. So we develop and provide software tools that are installed and used by doctors. Health information exchanges may help convey information from one point to another, but often they don't look at the content. You might think of them like a mail carrier who picks up the mail from one location, doesn't open the envelope, and delivers that envelope to another location. So to more effectively protect disclosures of private information, we recommend that privacy laws and supporting regulations be written to include as stakeholders groups like doctors and hospitals so that their feedback can be given on both the construction and the implementation of such laws and regulations. My final recommendation has to do with the timelines. This particular legislation allowed 6 months for implementation. Though all parties worked aggressively to implement the current requirements, we saw that there was a burden of the short implementation period that fell on doctors and hospitals who need time to update their software and information systems, train their staff on new expectations, and explain the changes of what's happening to both their patients and to the other caregivers that they share records with. So as Maryland considers future initiatives, we recommend 12 to 18 months be allowed for development of new features and another 18 months be allowed for providers and healthcare organizations to be able to implement those features. Thank you again. I appreciate your passion for protecting patient privacy and your attention today to our recommendations about future laws and regulations that you might pursue. Epic welcomes any further opportunities to share our technical expertise.
Thank you, Sasha. Do I have any questions from the committee? Senator Lamb.
Thank you, Madam Chair. Just have one question to follow up on Ms. Turman. I know we don't have any privacy advocates that are speaking as part of this panel, but just out of curiosity for you, as part of Epic, which I know is one of the largest EMR companies out there that supplies many hospitals, including many here in the state, did you have any conversations with kind of privacy advocates or local privacy advocates as you were working on these recommendations?
Yes, we did. We consulted and designed in conjunction with users of our software, and we had multiple perspectives represented, both patients, privacy advocates, the physicians who treat the patients, and other caregivers.
Okay. All right, thank you.
I don't see any other questions. Thank you very much. With no other questions, it's going to end the hearing on this portion of our briefing, the data privacy for legally protected health care. And next, we're going to do the report on the prior authorization process and recommendations. And again, it's Ben Steffen and David Sharp.
We're going to cover basically the recommendations, recognizing that you picked up a good part of your time alive reproductive health.
We appreciate that, Mr. Steffen. We do have another briefing after all the health care, so I appreciate your consideration.
And the slides, just to, are we good? Okay. So it's still, we're going to work through it? Okay.
Get to your next one.
Okay. Okay, I think we're set. So thank you, Madam Chair and members of the committee. It's a pleasure to be here before you today to talk a little bit about the, the Health Insurance Utilization Review and Revisions Law that set forth the study that was conducted by the Maryland Healthcare Commission and subsequent recommendations. So I'll just touch quickly to keep things moving for you on what you're seeing on the slide, and I'll move expeditiously to the recommendations. So you probably recall that the law passed during the 2024 session. It was titled the Health Insurance Utilization Review and Revision. A couple things to point out on it. It includes several provisions pertaining to health insurance utilization review, internal grievance, and adverse decision procedures, payer reporting on adverse decisions, and the provision of patient benefit information. And what's important to note here is, as it relates to electronic health records, by July 1st, 2026, payers are required to link to e-prescribing and electronic health record EHR systems, accept and timely review electronic prior authorization requests, and link to real-time patient out-of-pocket costs, which are the co-payments, deductibles, and co-insurance, and more affordable medication alternatives. The law requires the MHCC and the MIA to study the development of standards for modifying prior authorization requirements for prescription drugs, medical care, and other services, including state-level approaches. There was a report required, and it was submitted by the due date to the General Assembly of December 1st of last year. So the environmental scan, just quickly, we started the environmental scan in June of last year. We looked at both what was going on in the literature and what was going on in the vendor community. We explored federal and state reform as it relates to prior authorization. We worked with the MIA on the adverse decisions policies, and we looked around at what's going on at the federal level regarding interoperability of prior authorizations. We touched upon gold carding programs and the real-time benefit tools, as well as the perspectives on the prescription drug coupons. The findings provided the foundation of the environmental scan for the three recommendations, which I'll touch upon in a few moments. Just briefly, on the federal side, it's worth noting that the Centers for Medicare and Medicaid Services released in January of 17th of 2024 interoperability and prior authorization final rule. The rule includes requirements for providers to be able to identify prior authorization requirements, retrieve necessary patient information, and exchange requests and responses within EHR workflows. So the idea is to keep everything in the solution and allow access for the provider at the point of patient care. Payers are required to issue decisions on non-urgent prior authorization requests within 7 calendar days and expedite urgent prior authorization requests within 72 hours. Specifically, reasons for denial of prior authorization requests and public reporting are included in the final rule issued by CMS. So let me hit the recommendations, which are really built upon two things. One, the work of the environmental scan, and two, which follow suit to the policies of the federal government. So the recommendations are lining up. So Maryland is pretty much in the same direction as what the federal government is thinking. So turning to the first recommendation. The first one, assess the impact of commercial payers, including an indicator on claims that required prior authorization in their quarterly submissions to the MHCC All Payer Claims Database, starting in 2026. The rationale here is that reporting prior authorization metrics increases transparency and allows for a general measurement of spending to assess the impact of prior authorization on payers, providers, and specialists, as well as consumers. The second recommendation, require EHR vendors to implement an electronic prior authorization application programming interface in accordance with the CMS interoperability and prior authorization final rule, which I previously noted on a slide. Encourage commercial payers to use an API implementation guide specified by CMS. Briefly on the rationale. Stakeholders have expressed concern that absent a mandate on EHR vendors, providers may struggle to identify prior authorization requirements, retrieve necessary patient data, and exchange requests and responses with payers within their workflows. And the third and final recommendation. The recommendation here is to monitor the implementation and impact of the 2024 law and any future amendments on providers and commercial payers, and submit an annual report to the legislature through 2028. The rationale, continuous monitoring helps ensure implementation of new prior authorization requirements are reasonably progressing and provides opportunities to identify policies and practices that may need to be reviewed to inform future legislation consideration. So the three recommendations summarize the work that was required in the study and the outcome. The report was due by the end of the year, and it was submitted timely as well. I'm happy to answer any questions.
I don't see any questions. You did a good job.
Thank you.
Go into your next presentation.
Yes, ma'am.
Okay, good. Lots of papers. This is the telehealth study findings and recommendations. And again, Mr. Steffen and David Sharp. Thank you.
I'll talk about that one slide.
Okay. Good afternoon again, Madam Chair. The prior presentation will hit on the highlights and try to be expeditious for you on the time. So the background of the study, just to call your attention to the law that required us to do this work, was built upon some of the prior initiatives of the General Assembly legislation, specifically the Preserve Telehealth Access Act of 2021, which requires study on the impact of expanded telehealth coverage and reimbursement for somatic and behavioral health care. That report was delivered to the General Assembly in 2020, at the end of 2022. There was also a study letter sent to us from the HGO to the MHCC, looking for us to provide feedback and recommendations that build upon actions taken by the health occupation boards to enable alternative pathways to licensure for telehealth. The legislation specifically that we're talking about today is Senate Bill 534, Preserve Telehealth Access Act of 2023, and House Bill 1148, Behavioral Health Treatment and Access. Both of the study requirements appear in these two bills, as you probably recall. So the law extends the use of audio-only telehealth through June of 2025 and requires reimbursement for telehealth services to be paid at the same rate as in-person by Medicaid and private payers. It also requires the MHCC to study and make recommendations on the delivery of somatic and behavioral health services through audio, visual, and audio-only telehealth. Here again, the report was due to the General Assembly at the end of last year, and that requirement was met. So in this slide, I yield to my executive director.
Thank you, David. So I just wanted everyone to look at this and remember that oftentimes when we talk about behavioral health, we don't distinguish the types of behavioral health conditions that clinicians are treating. Like somatic care, the conditions that patients may face are quite diverse. And as we think about when telehealth may be appropriate and when telehealth may not be appropriate, we need to increasingly map down to the specific diagnoses that the treatment is designed to address. So I think oftentimes we create a broad brush on what we ought to do across the whole spectrum of behavioral health care, but it's important to understand that the range of conditions and the range of treatments is as diverse as somatic care. We wouldn't claim to be performing cardiac surgery in a physician office or a ambulatory surgery center, but obviously it's appropriate in a hospital. Likewise, we have to recognize that many of the behavioral health conditions can appropriately be treated through a combination of in-person and telehealth, but some cannot. And we need to be mindful of that as we move forward. Back to you, David.
Thank you, Ben. Traveling along, so there are several key insight study questions, 4 to be exact. And what I'm going to do is just briefly touch on them and, again, to frame the study questions provided the foundation, the insights gleaned from them for the recommendations. So the first one, is it more or less costly for healthcare providers to deliver healthcare services through telehealth? Generally speaking, what the research showed is that the cost of telehealth services compared to in-person service varies based on the care site, the geographic location, condition being treated, and provider type. As it relates to the reimbursement levels for audio-only telehealth services, they've been fairly consistent across the different provider types and whether in urban or rural areas of the state. Study question 2, a brief glimpse at the insights. Does the delivery of telehealth services require more or less clinical time and clinical intensity on the part of healthcare providers? The level of relative clinical intensity of care provided using telehealth varies to in-person care. Trends show a decrease in relative clinical intensity for behavioral health services and office and outpatient services delivered using audio, visual, and audio-only telehealth. And it's important to note, as the lockdown scaled back, highest complexity of cases tended to move fastest to in-person. And lastly, the relative clinical intensity levels are generally lower for audiovisual and audio-only telehealth for most types of providers, except for psychiatrists in rural areas of the state. On our third set of insights, the question here is, are there aspects of telehealth that are subject to overuse or underuse or yield greater or lower value that help inform the debate on payment parity? A couple things to note. Increased use of telehealth services since the public health emergency is partially due to the recognition of value in improving accessibility. The commercial market has the highest share of combined behavioral health and primary care services performed via telehealth. And you can see the percentages, how they stack up between commercial managed Medicaid and then Medicare Advantage. Across all lines of business, behavioral health care services consistently have a higher share of services performed via telehealth versus in-person than primary care, which may be due to the difference of the mix of behavioral health and primary care services and the appropriateness of care provided via telehealth versus in-person. And lastly, on the key insights, is reimbursement adequate for behavioral health and services delivered in person via telehealth? Reimbursement for behavioral health services is lower than for somatic care, which often involves more procedural and surgical care and less cognitive services reimbursed in evaluation and management codes. Continued monitoring and analysis is needed to ensure that reimbursement policies are equitable and that virtual options remain available. So now we'll turn to the recommendations. Recommendation 1, allow use of telehealth by any healthcare provider licensed, certified, or otherwise authorized under the health occupation article to provide healthcare in the ordinary course of business or practice of a profession in an approved education or training program or for interprofessional consultation. This enables qualified providers to maintain the use of telehealth when needed to enhance the overall flexibility and responsiveness of the healthcare system. Telehealth modalities promote patient choice and efficient use of healthcare resources. Telehealth has achieved broad acceptance across somatic and behavioral health settings and specialties. Use of telehealth remains high and more consistent in mental health and more consistent for mental health and substance use disorder services. Virtual options enable a range of healthcare providers to improve equitable access and continuity of care. So our next recommendation, allow unrestricted use of audio only for behavioral health services based on patient consent to receive care via audio only. Allow for audio only for somatic care if the provider is technically capable of using telehealth, but the patient is not capable of or does not consent to the use of audiovisual technology. The rationale, if you will, unrestricted use of audio only for behavioral health services ensures broad access to mental health and substance use disorder treatments, particularly for individuals who lack audiovisual capabilities. It maintains patient choice in how they access care. Patient agreement to receive care via audio-only technology ensures that patients are actively choosing a communication mode that best meets their preference and circumstances. And lastly, possessing the technical capabilities to support audiovisual services in somatic care sets a standard for telehealth by prioritizing patient visualization whenever possible. Our third recommendation, maintain payment parity for behavioral health and somatic care delivered using audiovisual and audio-only technology. Preserving payment parity for behavioral health and somatic care delivered via audiovisual and audio-only methods ensure telehealth options remain practical for providers. Removes financial disincentives and promotes equity by allowing providers to use telehealth modalities that are most accessible to their patients. And lastly, it reduces the stigma that can be associated with in-person behavioral health visits, helping to eliminate barriers to care. And that concludes my presentation on the recommendations and the work. Happy to answer any questions, Madam Chair.
Thank you for your work and for this presentation. We will have a bill this year to continue the use of telehealth. And just on a personal note, we're not for behavioral health, but when my dad was in his 90s, sometimes it was so much easier to have a telehealth with his doctors, and my sister and I there to answer questions, than to hire, an ambulance paramedic to take him to the doctor's office. It really helped us tremendously. So I think for a lot of people, transportation's an issue, taking time off from work is an issue, but I know that it works very well, particularly behavioral health issues for a lot of people, so I really appreciate your work. Do I have any other questions for Ben or David? Thank you both very much for your work. I know you did a lot more work than just these 3 reports, but I really appreciate both of you. Thank you.
Thank you.
Thank you, Madam Chair.
We're a little bit ahead of schedule thanks to the consideration of MHCC.
I do have to end this.
So we're gonna end this, but don't leave. Thank you.